Thank you so much, McKenna, and hello to all of you who are joining. Thanks so much for jumping in today. My name is Rod. You guys can call me Rod. I'm a general surgery resident, and I think that today I kind of want to do a mix of a few different things. I know that people are getting shadowing credit, so we'll do a little bit of a case. We'll talk about general surgery residency, general surgery as a career path, and a little bit about research because I'm currently a research resident. So we can kind of talk about that as well and my predictions for how research is going to be changing over time. And maybe by the time you guys are surgery residents, it'll look totally different. This whole field will look totally different. So, all right. So again, my name is Rod. I'm a PGY3. That means postgraduate year 3. I am a general surgery resident at Wright State University in Dayton, Ohio, and I'm currently doing dedicated research time at Cincinnati Children's Hospital Medical Center with their pediatric surgery department. So today, like I said, we're going to go a little bit about, we'll do a case, we'll do a little bit about general surgery residency and training, we'll do a little bit about careers, and then we'll kind of dive into research and my own kind of thoughts about general surgery research. So about me, I'm from Cleveland, Ohio. I did my training at University of Cincinnati. And then I went to medical school at Wright State University in Dayton, Ohio. And then I ended up staying here for general surgery residency. So general surgery residency overall, for any of you pre-med students who are thinking that, I want to be a surgeon, I'm going to say, it's not totally like what you see on TV. And these are some of my favorite TV surgeons. But, it's kind of like that saying that, there's some truth to a stereotype. And a little bit of that kind of mixes into what the general public thinks of surgery residents and trainees. So the first thing I tell folks is that a lot of general surgery residency is life and death. I think that this is one of those specialties that you're very close to patients who are dying or close to death. And there are a lot of situations, especially if you think of, trauma surgery or vascular surgery or some of these, or surgical oncology, where mortality is a really big part of the training. I think of time, not just time as in hours in the day, because I would argue that general surgery residents are some of the busiest residents in the hospital, up there with, I would say, like OB-GYN residents or neurosurgery residents. Those ones are probably a little bit worse, but general surgery is up there with time. And then not just time with hours, but time as far as years, because general surgery training takes several years. And I'll dive into that a little bit. And then careers. I think general surgery is it's training that prepares you for so many different subspecialties, because you really do learn how to operate anywhere in the body. So you have a lot of options at the end of training for different fellowships and different careers. And it's very broad in that sense. I personally chose general surgery for a couple of reasons. One is, in a previous life, I was a musician. I used to play drums. So to me, when I was in medical school and I got to do my surgery rotation, it felt very natural to help patients with my hands, to get to use my hands, to get to use tools. It was very comforting to me that I could help another human being or heal another human being that by those means. And the other thing is instant gratification. I have a terrible attention span, and I'm not the type that, I love my colleagues in primary care, but I'm not the type that would be able to sit and tinker with meds for, 6 months at a time and try and see changes or something like that. Like, I need the instant feeling of, someone comes in, they need their gallbladder out. We take their gallbladder out, and the next day they're going home and they're, eating ice cream. I need that type of turnaround in patients. And you get that with surgery. So surgical training in the United States, for those of you who don't know, when I said, it takes a lot of time, I mean a lot of time. So you have to do your 4 years of college. You have to get a college degree. You have to do 4 years of medical school. Traditional medical school in the United States is 2 years where you're going to the classroom, 2 years where you're in the hospital doing rotations. And then you decide what kind of specialty you want to do. If it's surgery and you go into surgical residency, even the number of years of surgical residency can kind of vary. So typically there's 5 clinical years, meaning 5 years of being in the hospital, treating patients, being in the operating room, learning that. And then there are extra years for research, anywhere from 1, 2 to even more. I know some people who have taken 5 years to do research, basically getting their PhD in the middle of their surgery residency. Now, typically you do that after your 2nd or 3rd year of clinical training. So kind of in the middle, you do a couple of years of clinical stuff and then you go off to do research. And then once you complete your surgical residency, then you decide if you want to subspecialize, then you could do a fellowship. Now from general surgery, you could do, almost anything under the sun. You could be a trauma surgeon, you could be a vascular surgeon, surgical oncology, breast surgery, colorectal. There are so many different training programs out of general surgery residency. You can get really deep into the weeds. And if you want to, you can even do multiple fellowships. I know a lot of pediatric surgeons at Cincinnati Children's who have done pediatric surgery fellowship and then also a transplant fellowship because they want to be a pediatric transplant surgeon. So there's a lot of options there. And then once you're done with your fellowship, then you become what's known as an attending, or you're the person who's then teaching all of those other bullets that are above it there. And I would argue that even being an attending, there are levels to that too. There's the fresh attending out of fellowship who's new, young, and maybe doesn't have as much experience as someone who's 10 years out of fellowship. And then the chair of the department who's maybe 20 or something years out of fellowship, and they're a wealth of knowledge and experience. So there's even levels to being an attending. So when you are a resident, this is a typical day for a clinical resident, not for me as a research resident, but usually when I'm on rotation, I try to get to the hospital at 5 a.m. I'm pre-rounding at 6 a.m., meaning I'm going and checking on the patients. Maybe you get sign out from the night resident and find out what happened overnight with your patients. Then you go and check them out, make sure that their wounds look okay and everything. Around 7 o'clock, you're probably going to run the list, meaning you'll meet with the rest of your team of residents and you'll talk about each patient, say like, hey, here's what happened overnight. Here's how the morning labs look, how the blood work looks. Here's what they looked like on physical exam today. Here's my plan for today. I want to change these meds. I want to take them to the OR. I want to send them home, or whatever that is. And then the operating room, usually the first surgeries, or what we call cases, the first cases are going to be at starting sometime around 7:30 at most hospitals, meaning that you're going to be in the operating room for these scheduled surgeries, or maybe not scheduled surgeries. Sometime around noon or in between cases, you're probably going to round with the attending and some of the surgical team. And then for the rest of the afternoon, you're either in the operating room, at a computer, writing notes, doing orders. Usually around 6 in the evening, you're probably going to give sign out, meaning you're going to tell the night resident what's going on with all the patients, what happened with them, and what to expect overnight if they're going to get any calls. And then after that, finish up your notes, leave the hospital. I have a personal rule for myself that I don't like taking work home with me. So I try to finish all of my notes and orders and everything before I leave the hospital. For me, usually that's somewhere between 6 and 7, depending on how the day goes. And then you wake up and you do it again, 6 days a week for 5 years at least. All right, so let's jump into a little bit of a case. Unless McKenna, is this a good break point? Are there questions or anything about that stuff? Or
no, not yet. I think this is a good point to do that.
All right, so we'll jump into a little case here. So you got a 9-year-old boy who comes in. He's got acute onset right lower quadrant pain. So he comes in, he's hurting, he's holding his belly. Let's say you are shadowing me. What kind of stuff would you ask this kid? Why don't we put that in the chat? What kind of stuff would you ask this kid if, I sent you into the room to talk to him. What would you want to know about this pain in his belly? He's 9 years old, so he could talk to you. And let's say his pain isn't so bad that he, is wailing and screaming, but he's really hurting. What kind of stuff would you guys say? What do you think? Or what would you ask? What would you want to know?
Okay. How long has this been going on? Is it a throbbing pain or is it continuous? So what type of pain? We said how long, what makes it worse?
These are great questions.
Maybe ask him to pinpoint exactly. Show you, are there any other symptoms? Again, is it the first time this has happened?
Wow, you guys are good. You guys are good students. These are great questions to ask. I would want to know all those things too. So we're going to do that. We're going to go do a history and physical. So just to answer some of the questions that are in the chat, you guys had some good ones. He says his pain is 8 out of 10 if he had to rate it. And it started 8 hours ago. It started at his belly button, and then it moved down to his right lower quadrant. And then we're going to push on his belly. This is what we all do as surgery residents. We're going to push on his abdomen, and he's significantly tender in the right lower quadrant. And then when you push on the left lower quadrant, somehow that causes pain in the right lower quadrant. That's kind of weird. You're going to look at his vital signs. So I want to know if he's crashing right in front of us. That's probably important to know. All right. So I gave you some information there. Why don't you guys put in the chat here, what do you guys think is going on with this kid? What's your differential diagnosis? What are you going to say? I think this is why he's having this pain right here. This is why he came to the hospital. And just to reiterate, it's a 9-year-old boy, pain in the right lower quadrant, 8 out of 10 pain. And for about 8 hours, started his belly button, went over to the right lower side there. So see some good stuff here. Irritation, inflammation, AAA. AAA. I like AAA. AAA stands for abdominal aortic aneurysm. Certainly could be a cause of abdominal pain, but you're going to see that in elderly patients, or typically it's white middle-aged or elderly men who smoke is kind of the person who would get AAA. Inflammation, irritation, those are not necessarily a diagnosis, but those are things that I would say describe what's going on. They're definitely things I would say describe going on. And then it looks like the most popular thing that people are saying is appendicitis. That is probably the most likely thing going on, spoiler alert. But here's really quick how I kind of break down a differential diagnosis when a patient comes in with abdominal pain is where is it? And then just think of anatomy. I don't know how many of you guys took anatomy. Maybe that's part of the reason why some of you guys said appendicitis, but I usually think where's the pain and then what's under the skin there that could cause this pain? What could be going wrong under there? If you look at the right lower quadrant, that blue square, there's a lot of stuff anatomically that could be there. So if this was a female, then you could think of gynecological reasons. You could think of anything that could be like an ovarian torsion or a cyst or things like that. Certainly inguinal hernia, but that would be a pain that would be more so in the groin instead of the right lower quadrant. So appendicitis is definitely up there on the list. Okay. So what we're going to do next, we're going to get some blood work and we're going to get some imaging. So we get some blood work and it says the white blood cells are 17. That's kind of high. That's kind of what someone else said in there. Inflammation. This is kind of a marker of inflammation. Hemoglobin is 13. That's fine. Platelets are 250,000. That's fine. And then, we're going to look at an ultrasound. So for this kid, we got an ultrasound and you could see that circle there. So I'll get into a little bit about ultrasounds in a bit, but that circle there, that's the appendix. We're kind of looking at it in a cross-sectional view and it's a little bit big. Okay. So we have a dilated appendix. We got inflammation in a little boy. This is appendicitis. So what do we do for appendicitis in 2021? We do minimally invasive surgery. We do a laparoscopic appendectomy. So we go into the abdomen with these tiny tools. One of them has a camera. Two of them have little graspers on chopsticks. This isn't an appendectomy, but this is a laparoscopic surgery here. You can kind of see how it would look. You have your cameras up there, and then the surgeons are using these little tools to drive around. It's kind of like a video game. Now here is the laparoscopic view of an appendix during, maybe this is an appendectomy. It looks kind of like an angry appendix, but that little pink worm-like structure is your appendix coming off of, if you follow it down on the right-hand side there, it goes into your colon, the first part of your colon called the cecum. So these days we cut it off with a stapler or tie it off with a suture. You don't have to do the incision that people used to get like in the 90s. And you take the appendix out. In pediatric patients, this is the most common surgery performed by any pediatric surgeon in the country. So to recap, appendectomy is the most common pediatric surgical operation. In adults, if their appendix is angry and inflamed, they're usually going to get a CAT scan. We try to avoid that in children, do an ultrasound because radiation. We don't like to expose kids to a whole lot of radiation. Ultrasound doesn't have any radiation. And then controversial topics, you do antibiotics and non-operative therapy was what NOT stands for. So there's starting to be a little bit of evidence in the literature that maybe not all these patients need to have a surgery. You can give them antibiotics, send them home, and some of them will not need a surgery. So a little bit about CAT scans, the donut of truth. This is what it is. You put the patient on there, you put them through there. It takes essentially it's kind of like a bunch of x-rays from different directions. And then you can kind of, from that, look at a patient like almost like you chop them up like sliced bread. So if they were laying down, you're looking at all these cross-sectional images. It's kind of like you could take one of those out and look at it wherever the piece of the bread where the appendix is. You could look at it from a cross-sectional view and kind of see if anything's going on. Again, we used ultrasound in this pediatric patient. I don't know how many of you pre-meds took physics yet, but the way ultrasound works, basically you got crystals in that little thing and they vibrate. And then that vibration sends out a wave. The wave goes out and hits objects. And then based on the density of those objects, it sends back a reflective wave. And then from that information, we get this kind of gray-scaled image that we were looking at earlier to look at the appendix. So that's how ultrasound works. So it's no radiation as opposed to the CAT scan, which uses radiation. All right, so while changing gears again, so the expectation of the surgical resident these days is that while you're doing all this stuff, working, 12, 14-hour days, and in the OR, learning how to take out appendices and stuff like that, you also are supposed to be doing research. A lot of programs, a lot of residency programs push their residents to do some sort of research, and traditional research options are kind of listed there. Lab, bench work. I've done that when I was an undergrad. You're sitting pipetting stuff, running PCRs, things like that. Translational outcomes research, quality improvement. That's more like the clinical type stuff, whether you're, testing new therapies, be them drugs or surgeries, looking at clinical outcomes on different types of surgeries, like back when laparoscopic appendectomies were coming out, there's people saying, oh, should we do them open or should we do them laparoscopic, and do a clinical outcomes study on it and look at which one has better outcomes. Quality improvement studies. So those are really popular these days as well. Things like what's called ERAS, or enhanced recovery after surgery. We're finding that maybe the not just the surgery, but the care for the patient before and after surgery can have a really big effect on how fast they recover. Whether it's feeding them sooner than we used to, or giving certain antibiotics at certain times, or giving people physical therapy, getting them up out of bed, even though they're in pain from their surgery. We're finding all these different things that help around the surgery. And a lot of that would be under the umbrella of quality improvement. Now, a lot of times the amount of research that residents or fellows or attendings are expected to do has something to do with a designation that we kind of colloquially say academia, or academic surgeons, meaning surgeons who are at big, fancy academic institutions. Think of the big name brand hospitals that are out there that you know of. that have a lot of money and they can put money towards research projects. Those would be kind of what people will call academic institutions. Cincinnati Children's Hospital, I would say, is certainly one of those places, versus the community residency programs that are just training. They just want to train residents to be capable surgeons by the end of graduation. Now, every residency is trying to do that. But what I'm saying is that a lot of times community programs, they don't care that much about pushing out research and stuff like that. They care more about training someone who's going to be totally independent at the end of those 5 years. Mostly because, if you go on to fellowship, you're going to keep operating under another attending or something like that. So that's kind of the mindset. It's kind of like a rule of thumb. And I apologize if I offended anyone who's either academic or community-based, based on what I said. But the idea is the academic surgeon is the pressure is to publish, to be someone who's contributing to the literature. And there's also an expectation, I would argue, to be a big person in these member societies. So there are a lot of surgical societies out there, a lot of surgical societies, a lot of surgical journals. And there's this kind of expectation that academic surgeons or researchers are people who are going to be giving, lectures and speaking at different grand rounds and speaking at conferences and things like that. So the academic surgeon, I would argue, is also supposed to be doing all this stuff along with their research, whether it's, like we said, bench work or anything like that. And then on top of that, there is an onus to help with education. So education in the surgical field is reliant on, like I said, conferences, societies. It's reliant on textbooks, journal articles, and the academic surgeon is expected to participate in all these things. Write chapters, write journals, get published, go to society meetings, and give lectures. I'll tell you that the reason that I took on my position with Cincinnati Children's, specifically, I took a job with an attending who is interested in surgical education, because I didn't want to sit in a lab. I didn't want to crunch numbers and do outcomes research. I wanted to figure out how we can train surgeons in the future, or how we can train surgeons maybe more efficiently or more practically. So where do I think the future of surgical education is going? Well, where do any of us go to learn anything? We go to YouTube, right? I don't think surgical education is any different than that. People want videos and, they want their media to be consumable and easily accessible. And if you go into YouTube, you can find surgical procedures, people explaining step by step how to do these different things. And so there's one area, content moving towards, more of a digital aspect instead of textbooks and society lectures. And then there's another area that I would argue is becoming popular, which is audio-based content. For example, podcasts. Here's a little sample of one of our pediatric surgery podcasts that we put out every week. This is one from a few months ago.
Today I want to talk about a 4-letter word.
Can you guys hear it?
Pimp. Well, at least in medicine, it's like a 4-letter word. No. You see, I don't mean pimping like the way Snoop Dogg talks about it. I'm talking about the kind of pimping that you see on Grey's Anatomy.
Name the common causes of post-op fever. From your head, not from a book.
So doctors around the world learn a lot about clinical medicine from this style of teaching. And we call it
pimping.
Pimp questions, pimping.
Pimp questions.
It's that constant barrage of clinical questions from whoever you're learning from. And we continue to use it because we believe that
you'll never forget something.
And if you get it wrong, you'll never forget it.
When I get a question wrong, that's something I'll never forget.
Download the Stay Current app to hear the entire episode.
So that's one example of, that was a history one. That one's more fun, but we have other podcasts that are about biliary atresia or, different gallbladder pathologies. So why are people moving towards podcasts? Well, first of all, I think a lot of people during the pandemic have moved towards podcast content, but then also surgeons, and particularly it seems like a younger generation of surgeons, they don't have a lot of time. They want to learn as efficiently as possible. So they're going to listen to a podcast on the way to work, or they're going to, listen to sometimes audio books, audio textbooks, and things like that. So I think well, first of all, I'm biased because I also host a pediatric surgery podcast, but I anticipate that your generation of physicians will be similar in that, you guys are going to consume medical podcasts in some form or variety, whatever that is in the future.
Today,
And the next thing I want to point out is social media. So obviously I don't have to tell this group of people the power of social media, but oftentimes with the current generation of attendings, depending on the institution you're at, sometimes there's a little bit of coaxing to explain to them why they need to be either investing, participating, or helping their residents to participate in social media. And I think it's a great tool to spread knowledge, to spread information. So for example, I work for the Journal of Pediatric Surgery, which is arguably like the largest pediatric surgery journal, or most credible pediatric surgery journal in the United States, maybe up there most credible in the world. But I'm one of their I'm their only social media content creator. And they wanted to know how we could review journal articles on social media. And I said, well, everybody's on TikTok. So here's an example of a Journal of Pediatric Surgery article review.
Hey, is this surgery? Yeah, this is surgery. Yeah, this is John from radiology. John, what do you want? I just saw the x-ray. You got to pull the catheter tip back. John, why do you have to call and ruin my day? I'm Rod from Cincinnati Children's, and it looks like somebody should have read this article. In this study, the researchers looked at about 90 neonates who necessitated a right internal jugular central venous catheter. They tried to determine which factors correlated the most with the depth of the central catheter tip. What did they find? Of all the factors they looked at, weight had the strongest correlation with the depth of the tip. And from that, they derived a calculation. Y equals 2.6 plus 0.7 times the weight in kilograms. And Y equals the depth of the catheter tip. The next time you have a neonate who needs a right IJ, you should try out this formula.
And to be fair, probably the average age of the editorial board of the Journal of Pediatric Surgery is probably in their 60s, and they have no idea what I'm doing here, but they're very much like, do it because this video got it got like in the tens of thousands of views, so I try to do one almost every week. And they're getting a lot of views on TikTok, and we'll put them on Instagram, and we'll put them on Twitter, and people are watching them. So whether you like them or not, people are consuming content. I think that there's a body of medical trainees and professionals who consume their content in places like TikTok. So,
hey, is this sir?
And then my boss actually created an app, a pediatric surgery app. And when he came to me when I first joined him to start working for him, he basically had one task. He said, I want you to come up with whatever you can to that you think is going to change surgical education in the future. And come back to me and we'll put together whatever project you think that's going to be. So I showed him an idea for what we call story casts, because I'll show you this in a second here. This is a combination of basically like a choose your own adventure story a clinical case and the accessibility of a podcast.
Hey, there you are. I just got the call. 5-year-old male pulled from a house fire. Vitals are listed here. What should we do first?
And then here's where the user selects a choice.
All right, airways intact. Breath sounds are equal and present bilaterally. You have distal pulses down there? Awesome. Only thing I'm worried about is I see some singed nose hairs. What do you want to do? All right, tubes placed. He's moving air on both sides. O2 sat's coming up. It's at 98%. All right, go ahead and get large bore IVs in both arms. Yeah, let's get respiratory therapy in here. What do you want to do?
So it's an entire surgical case where the user decides how the case goes. And you might save the patient, or you might not save the patient. And if you don't, then there's a teaching point, and it will give you articles. It will give you a summary of how you did, what you did wrong. So this was our pitch, and he loved it. And now we have 3 or 4, I think we're creating our 4th surgical case like this on our app. So where does this go next? My research, I put it in air quotes because it's not a very traditional form of research, is in surgical education. And where's surgical education going next? I think it's going in a lot of directions. It's going in augmented reality. It's going towards AI. It's going towards machine learning. It's going towards these technology-based applications and how we can use them in surgical means. And I don't think that, I think that if you try to predict what's going to be next is when, you're going to be wrong. Because I think that what we're coming to find is that surgical trainees, surgeons from around the world are coming up with all these fantastic ideas. And, I'm just excited to see what everyone else comes up with. So I wanted to leave some time for questions. So that's the end of my talk. Here are my social media handles. And then I'm happy to answer any questions or, comments or complaints if you have them. But otherwise, thank you guys for having me. Thanks for reaching out. And, I'm honored to get a chance to talk to y'all.
Thank you so much for talking to us. I think I can speak for all of us, and I say that I really enjoyed it. So like you said, if you guys have any questions or anything, go ahead and type it in the chat, and then we can read it. I can, I'll go after Vilma. She said your career seems very busy. How do you avoid burnout?
That's a great question. I think that general surgery, surgical subspecialties in general have a very high rate of burnout. And a lot of that is because of, kind of like what you said, because of the hours, because of the emotional toll that it takes on a lot of people, because if you think about it, you're dealing with, death on a regular basis. So, and I've had plenty of attendings who have told me, you miss your kids' soccer games because you're in a case, you miss, important things because you're tied to, maybe something goes wrong in the operating room and you have to stay late or something. So I guess for me, the way that I try to avoid burnout is, first of all, I think I'm usually a very positive person in general. But I think that a lot of it is enjoying yourself, not just while you're outside of work, but while you're at work. And I don't know, people tease me all the time for, joking around and being on Snapchat and stuff like that while I'm at work with my residents who are my friends. And it's like, oftentimes you kind of need that. You kind of need to, when you're typing out notes, you need to listen to music that you like. You need to joke around with your friends. You need to eat a sandwich at the end of a long case. You got to think about that kind of stuff. It's hard to kind of pull yourself away from the job sometimes. And a lot of residents, it's, sometimes impossible. But for me, that's kind of how it is you have to kind of enjoy yourself. Not just work to, because you're excited about getting home, but work because you enjoy doing it is kind of my thought. And whatever that is whatever that context is for you, then I'd say roll with it. How did you know that you wanted to be a surgeon? For me, I actually went to medical school because I wanted to be a pediatrician, and I did my pediatrics rotation, and I was bored out of my mind. My dad's a pediatrician, so I thought that I wanted to be a pediatrician because I loved, I worked in his office and stuff. I really enjoyed it, but I was really bored. I don't like just sitting around and rounding and stuff like that and writing notes. So when I was in my third year of medical school and I got to be in the OR and I got to actually do stuff, like I got to, if a patient's bleeding out and you're right there, they'll say, med student, put your hands there, and you're holding pressure on something that's bleeding. For me, it was the hands-on experience. It was excitement. So what's your favorite part of pediatric surgery? The patients, hands down. The pediatric patient, I think, is the most rewarding patient population in all of medicine. Because I don't know, there's just something very special about being fortunate enough to take care of a child, being trusted with a child. When a parent trusts you to take care of their child, there's just something really, I don't know, warm, fuzzy about that makes you feel good that you're helping a kid. So I think that's my favorite. What's the follow-up question to that would be, what's the worst part of pediatric surgery? Probably the parents, or anytime you take care of a pediatric patient, parents are the worst. And I know that I'm the worst. I'm a parent. I have 2 little girls, and I know that I'm a terrible patient parent, or you know what I mean? Just because it's your kid, you're worried about it. And sometimes you don't have a lot of logic when you're like that. How do you think AI will be used in medicine and surgery? I think that it's already being used. First of all, you can look up at articles that are a machine-based platform to determine from, if a patient has appendicitis, and there'll be some study on how I just saw one, how they let an AI look at a bunch of ultrasound images of an appendix and determine whether or not the kid has appendicitis based on whatever outputs that they gave it. Or so AI is being used in a lot of ways now. I think a lot of people predicted that radiology would be the first to kind of accept it, because you just give it a bunch of images, say these are the rules, tell me if this patient has this diagnosis. So you can find a lot of things where AI is being used, for that. And then sometimes treatment algorithms too, you could plug in. That will be nice if we could have predictors for how a patient's going to do, based on certain parameters or things like that, but who knows? How did COVID-19 affect your specialty in research? I work from home. That's how it affected it. So because I don't do so when you're in general surgery residency and you take off time to do research, you're usually not really taking care of patients as well. You're just kind of dedicated to doing research. So I mean, I'm not seeing patients. My research doesn't necessitate that I am in person and stuff like that. So I've been working from home, and it's been great. But the flip side is all of my colleagues have been slammed. Surgery residents get a lot of ICU training. So I know a lot of my friends were repurposed to work in COVID units, to work with, respiratory therapy and stuff like that for patients who are all on ventilators, because we get a lot of training on ventilators. So it changed surgery trainees. they had to change gears, and a lot of them had to go from operating all the time to being in the ICU and rounding. And then, like I said, for me, the difference was I didn't move to Cincinnati. I just stayed in my house, and now I just, make TikToks. Why did you decide to become a doctor? So I come from how do I want to frame this? I came from I'm in a family of doctors. Both my parents are doctors. 3 out of 4 grandparents, like 5 of my aunts and uncles are doctors. And I'm like one of the only grandkids who is a doctor. So my parents didn't really pressure me and my siblings. I'm one of 4. And the way I put this is I'm a surgery resident. My older brother, he's a musician in New York. So there was really no pressure at all to do medicine. For me, it was because I when I was in high school, I realized that I can't, play drums for a living. I'm not that good. So I worked at my dad's office. I kind of liked what my parents did. They seemed really happy people. I was doing well in science. I was always volunteering. I liked helping people. So medicine seemed like a really natural fit for that. And my parents were kind of like, "Oh, are you sure about that?" So they made me kind of volunteer and, work in a hospital more. And so for me, it was a mixture of being exposed to it. I really liked science. I liked helping people. I thought it might be a good career for that. And then because of that, my parents kind of forced me to get more exposed to it, to make sure that's a decision I wanted to do, which I would definitely recommend. Even if you think like gung ho, like, oh, I'm definitely going to be a doctor. Like there's always more aspects of the medical field that you don't know about, that you've never seen. So I would recommend all of you guys like get out there, volunteer, try and get some, I guess it's hard now with COVID, but shadow as much as you can, kind of get exposed to as much of the medical field as you can. And yeah. How do you deal with the loss of patients? It sucks. I mean, I still remember the first patient that died when, I wasn't really taking care of them because I'm the resident. So like the attending was, but you know what I mean? Like when you're helping the team take care of a patient and they pass away, it's incredibly devastating. More so when it's like a complication, when, it's something that maybe could have been preventable or something like that. It's really difficult. In medicine, there are a few ways that we go about that. I mean, obviously, if it is a complication, then you have to present that at the weekly, what we call M&M, Morbidity and Mortality Conference. It's a weekly conference. All the attendings, residents go to it, and you go over all of the complications over the past week. And they're presented. You say like, oh, this patient came in with this. The differential was this. We diagnosed them with this based on this. They underwent this surgery. Then this complication happened, and then the patient passed away, we think because of XYZ things. So you really like, not to use a pun here, but you really dissect the case out and try and figure out what happened. So when we lose a patient because of a complication, it gets really highly discussed, because the idea is we don't want that mistake to happen again, or that complication to happen again. And then there's always the situation where, if a patient passes away and maybe it's not a complication, it was just something that was maybe expected. I've done this. You sit down with your attending and you say, hey, what happened here? What do you think? Have you seen this before? Is there anything I could have done differently? And oftentimes it's like, no, because you're the resident. So you're not really making the important decisions here. So I joke. I mean, obviously it's gradient, or what do you call it? It's a graded level of responsibility, but you can always discuss the situation or concerns with the rest of the team, whether it's a chief resident or an attending or someone else. I think I would say the tough thing is when you put the blame on yourself. I wouldn't recommend anyone do that. And obviously that's impossible to do. How would you say pediatrics? Would you say pediatrics has a bigger toll on you loss-wise because the patients are kids? Oh, absolutely. Yeah. Like when you have a patient who's like in their 80s and they pass away, it's like, okay, well, they lived to their freaking 80. But, a child with a 2-year-old who has cancer, obviously, it's hard not to get emotionally attached to that kind of situation because, it's a 2-year-old with cancer. Like, how unfair is that? So it's definitely, the toll is very big. And several attendings I've talked to are like, oh, that when I remember when I took this job with Cincinnati Children's, a lot of them were like, oh, you're going to do ped surgery research. I loved ped surgery, but I couldn't deal with it because I didn't like dead kids. You know what I mean? Which is true. But I would argue that it's a double-edged sword. So yes, loss in a pediatric patient is arguably more devastating than in the adult patient. I think probably almost every surgeon that you talk to is going to say that. But at the same time, the opposite is also true, that when you save a pediatric patient, I would say it's exponentially more rewarding than saving, the geriatric patient. No offense to, maybe that's ageist. That's probably ageist. And I apologize if I offended anyone. But I don't know. To me personally, I think it weighs more heavily on my heart to save a child than it does, an older patient. So that being said, my mom is a geriatrician. That's not a joke. She's a geriatrician. So, I can see there's like there are a lot of parallels in geriatrics and pediatrics in that regard. And, obviously both are sad. It's a personal thing for me that I think, children are sadder. Maybe I keep digging a hole here. I'm going to stop there. Yes, I think it takes a bigger toll on me. That might be different for you, and that's okay. To any budding geriatricians in there, or my mom, if my mom is listening. Okay. It's 9:30, so that's the hour. McKenna, how are we doing?
I think we're doing great. If there are any last minute questions, go ahead and ask them. But aside from that, I am about to go ahead and send the link to the Google form so you guys can fill it out. So be sure just to click on that, and you just need to put kind of your name, your email address, how you heard about ISPR. It's all there. And if there aren't any last minute questions, then just thank you so much, all of you, for attending, and Rod for speaking to us. I absolutely loved hearing from you. And if you missed anything, it will be up on our YouTube, and their certificates will be sent out hopefully within the week. So I think that's all that I have. Anything else that you need to add?
I'm gonna say follow me on social media. I put my TikTok and my Instagram handle there. And then I guess if I had to give any advice to the pre-med students out there, I would say just enjoy college, because you're only in college once, hopefully. I guess it's okay if you have to be there for more or longer. That's okay too. But enjoy it, because when you get to medical school, I think that suddenly the pond gets a little bit bigger, and you're not the smartest person in OChem anymore. You're with everyone who's the smartest person in OChem. So enjoy your time, and good luck to all of you. You're gonna do great.